Hello everybody, my name is Anna Owens and today we will go over a clinical case study for patient LC. LC is a 32-year-old female. She is 175 centimeters tall and currently weighs 53.6 kilograms with a BMI of 17.4. Recently, LC experienced a 16-pound weight loss, which is about 12% of her usual body weight, which is around 61 kilograms, and which is in the range of her ideal body weight. Next, we will briefly go over her history. LC has a PhD in archaeology, and she works as an English archaeologist and treasure hunter. Last year, LC spent in the Gulf of Mexico looking for Jaguar God Cave. And LC is single, does not consume any alcohol or tobacco, and she is very active. Her favorite sports including mountain climbing, motorcycles, snowboarding, as well as daily exercising. She does have insomnia, and she follows strict vegan diet and has a private chef to prepare her meals. Now we go over LC's medical history and any medications she is taking. LC has a type 1 diabetes, and she's on a Humalog with an insulin pump. She also takes medication for inadequate production of thyroid hormone. LC was also diagnosed with Crohn's disease, which led to terminal ileal resection, which is a surgical removal of sesame and distal portion of the small bowel. Also, LC has been diagnosed with deficiency in vitamins D and B12, and she does take supplements for it. And now we will continue with her history of symptoms that led her current hospitalization. LC has begun to experience nausea, poor appetite, abdominal distension, epigastric pain, and weight loss in the past 3 months. Newer symptoms include vomiting, headache, cough, fever, diarrhea, night sweats, rash on her legs, and general malaise, after which she got admitted to the hospital. After admission, LC's condition started worsening, and she developed pulmonary edema and hypertension, after which she was intubated and placed in ICU on mechanical ventilation. At that time, a nasogastric tube was placed for the compression, as well as central line placed for total parenteral nutrition. Next, we will look at our patient's biochemical values that come back abnormal. Looking at the patient's blood work, we can see several highs and several lower than normal values. Higher than normal reference range results include potassium level, chloride, blood urea nitrogen, creatinine, alkaline phosphate, ACT, white blood cells count, slightly elevated A1C and C-reactive protein. The low levels show for creatinine clearance, albumin level, ALT, hemoglobin, red blood cells count, platelet count, and vitamin D. As a next step, LC was ordered an X-ray, ultrasound, and CT scan, which we will look at the next following slides. Abdominal X-ray show curvilinear soft tissue density cords, gaseous dilation of the stomach, and multiple loops of the small bowel. An air-filled tubular structure was found, which appears to be projecting over loops of small bowel in the abdomen and pelvis. Curvilineal structure were moving independently and identify in most of the loops of the small bowels. Abdominal ultrasound confirm dilated loops of the small bowel, which appears to be non-peristaltic, and according to a CT scan, this same tube-like structure appears throughout the small bowel. Mass in a distal jejunum and wall thickening of the terminal ileum that was believed to be mechanical small bowel obstruction due to ascariasis. During hospital stay, LC received several diagnoses as hantavirus pulmonary syndrome, valley fever, small bowel obstruction due to ascariasis, and severe protein-calorie malnutrition as a secondary diagnosis. In the next few slides, we will overview each diagnosis more closely. Hantavirus pulmonary syndrome is severe respiratory disease caused by infection with hantavirus that can be life-threatening. Hantavirus are carried by rodents and can be spread to humans airborne from rodent urine or by saliva or droppings. Incubation time can vary from 1 to 8 weeks. Early symptoms are similar to flu-like symptoms, such as chill, nausea, and headache. Then symptoms can include vomiting, diarrhea, and stomach pain. When the disease progresses, more serious symptoms can develop, like cough, breathing difficulties, irregular heart rate, and low blood pressure, and fluid will build up in the lungs. When the fluid gets built up in the lungs, it causes pulmonary edema, which is our patient LC experience, and that can lead to severe dysfunction of lungs and heart. Valley fever is caused by fungus, which can be found in soil in regions like southwestern US, Mexico, and Central and South Africa. In our case, LC most likely got infected with valley fever in Mexico, where she spent last year. Individuals become infected by breathing in microscopic fungal spores from the soil during wind, for example. Early symptoms of valley fever are similar to flu, such as chills, fever, cough, and can progress to more severe symptoms like shortness of breath, night sweats, joint and muscle soreness, rash on the lower limbs, and sometimes on the chest, arms, and back. The disease can affect several organs, especially lungs, skin, bones, liver, and heart. Mild symptoms may resolve on their own within a few weeks to a month. However, in the more severe case, medical attention is needed. Ascariasis is disease caused by roundworms, and these parasites use the body as a host to grow from egg to an adult worm, and they can be as long as 30 centimeters. Ascariasis is common in tropical and subtropical regions where poor hygiene level and sanitation. Ascariasis spread through contact with the soil that is contaminated with human, pigs, feces, or infected water. Symptoms can vary depending on what part of the body got affected, and in our patient, LC affected region is intestine. Egg mature into adult worm usually in a small intestine and live there until they die, which can cause mild to severe symptoms such as abdominal pain, nausea, vomiting, diarrhea, and a weight loss. Sometimes eggs can hatch in a small intestine, migrate into bloodstream or lymphatic system, and end up in the lungs. Symptoms can mimic asthma symptoms or pneumonia, like persistent cough, shortness of breath, and wheezing. If an individual has a heavy infestation, like as an LC case, that can lead to severe complications like malnutrition due to loss of appetite, poor absorption, and food digestion. Another complication that can be developed is a duct blockage to the liver or pancreas. Mechanical bowel obstruction can also lead to internal bleeding due to intestinal wall perforation. Our patient LC has also secondary diagnosis, severe protein-calorie malnutrition. There are a few possible causes that can influence this diagnosis. LC has Crohn's disease and terminal ileal resection, which can impact the body's ability to digest and absorb nutrients, leading to deficiencies and malnutrition. As we discussed, ascariasis can also lead to malnutrition by reducing intestinal absorption due to mucosal damage and by parasites. Also, diarrhea and vomiting dehydrate body even more. Even though protein deficiency is not as common in vegan diet as many may think, there is still the possibility that certain food restriction can lead to malnutrition. However, taking into account her recent diagnosis and symptoms such as vomiting, diarrhea, poor appetite, and malabsorption, all of that can be triggers to develop malnutrition. LC receive exploratory laparotomy, which is used to diagnose any abdominal issues. During surgery, the proximal portion of the jejunum was found to be necrotic. Ascariasis roundworms were found, and their length was between 12 to 38 centimeters and about 3 to 7 millimeters in diameter. Duodenum was found to be perforated, and palpable basal mass was found, which had the consistency of noodles. Basal mass was milked through the intestinal lumen into necrotic section of the jejunum. Also, the entire duodenum was removed, and end-to-end anastomosis was created. After surgery, LC recovered bowel function on the 4th day and was extubated. Her NG tube was removed and total parenteral nutrition was discontinued. To ensure patient get proper nutrients, a PG tube was placed for enteral feeding. During hospital stays, critically ill patients should receive adequate nutritional support to improve their clinical outcome. To determine appropriate energy requirements, the best way is to use indirect calorimetry. However, we cannot perform this test, so we will use one of the predictive equations. The Critical Care Medicine and American Society for Parenteral and Enteral Nutrition recommending calculating energy requirements based on kilocalories per kilogram of body weight. Based on LC's condition, that she is post-operative, underweight, and malnourished, we will calculate her stress level as moderate to severe, ranging her recommended energy needs from 35 to 45 kilocalories per kilogram. We do not want to underfeed or overfeed our patients, so we can start from 35 kilocalories per kilogram, which will be 1,876 kilocalories per day. And we will monitor her to see how she can handle it. LC's albumin level is very low. Also, her secondary diagnosis is severe protein deficiency, which is we have to address in our calculations. Protein recommendations for hospitalized patients with moderate to severe conditions vary from 1.5 to 2 grams per kilogram of body weight. Same as with calorie estimation, we will start from middle at 1.7 grams per kilogram, which will be around 91 grams of protein per day. There are several different methods to determine how much fluid patient requires, and the most basic method is the 1 milliliter per calorie. Another method is fluid balance, which is require a measure of urine output plus 500 milligrams per day, or method based on body weight, which is about 30 to 35 milliliters per kilogram. We will use the method 1 milliliter per 1 kilocalorie a day, which will be 1 liter and 876 milliliters fluid per day. Our patient LC is following a strict vegan diet, so when we are choosing her enteral feeding formula, we have to honor her preferences. Nestle company provides only one vegan feeding formula called Complete Standard 1.4. This formula is also approved for patients with diabetes, which work great for LC. Now we will need to calculate how much feeding formula volume LC need. Nestle Complete Standard 1.4 formula contains 1.4 kilocalories per milliliter, 72 grams of protein per liter, and 776 milliliters of water per liter. Based on this information, LC will need 1,340 milliliters of feeding formula per day, and which is about 56 milliliters per hour. Based on this feeding formula, LC will receive 96.5 grams of protein per day, which will meet her requirements, and 1.34 liters of Nestle formula will provide about 1 liter and 40 milliliters of water, and additional 836 milliliters will be provided throughout the day as a free water. Now LC's leg rash was resolved with fluconazole treatment, but she did develop some other skin rash and spotting. She was also diagnosed with disseminated intravascular coagulation, which is the blood clotting disorder. However, treatment with heparin helped LC. Also, she develops a stage 3 pressure area on her coccyx. A speech-language pathologist evaluated LC and no signs of dysphagia were detected, so her PAG tube was removed. LC was discharged a month after hospitalization, and so far she has regained 10 pounds and is scheduled for her bowel transplant. Here's the list of medications that were administered to LC during her hospital stay. She received an antiparasite, omeprazole for too much acid in her stomach, medication to relieve diarrhea symptoms and supporting her stomach after surgery. Also, LC was prescribed vitamin D, since her lab results show very low level. Next, we will look at the nutrition diagnosis statement and what nutritional intervention LC needs to receive. There can be several different nutrition diagnoses that be appropriate in most cases. However, we choose the most appropriate where the problem is urgent and must be resolved first. For LC, diagnoses are evident protein energy malnutrition related to mechanical bowel obstruction, reduced appetite, and malabsorption, as evidenced by loss of 12% of body weight within 3 months, BMI of 17.4, and albumin level of 1.8. When we are choosing what nutritional intervention appropriate for patient, we have to take into account their current and past medical history and lab values. We know that LC received terminal ileum resection prior to hospitalization, which can cause luminal bile salt deficiency, leading to fat malabsorption and colonic secretion by hydroxy fatty acids. For this situation, appropriate will be limited her dietary fat intake and add supplementation with medium-chain triglycerides and fat-soluble vitamins. Also, the ileum is essential in absorption of vitamin B12, and by its removal it can cause deficiency, which was diagnosed in LC. Additional B12 supplementation is needed, and one of the best way in LC case would be B12 injections. Since a large portion of LC's small intestine was removed, she most likely experienced short bowel syndrome. This can lead to nutritional complications such as malabsorption of essential nutrients and vitamins. For example, the duodenum is responsible for vitamins A, D, E, and K absorption, and jejunum responsible for protein, carbohydrates, minerals, and other vitamins absorptions. The nutritional recommendation for LC will include small frequent meals such as 5-6 instead of 2-3 meals per day. The liquid needs to be consumed between meals and not with a meal, because drinking with a meal can increase food transit time, which can lead to diarrhea and early fullness. Limiting simple carbs to avoid upset stomach, and avoiding glucose spikes, as LC is also type 1 diabetic. A high protein diet is recommended. Proteins tend to slow down food transit, avoiding stomach issues. Also, an adequate intake of protein will help heal patients' bed sore faster. For LC, protein options can include pea protein, quinoa, lentils, Brazil nuts, and tofu. Since LC has a low protein level, she may benefit from additional vegan protein supplements. Low-fat foods will be best to begin with, since high-fat products, even if they are healthy fats, may worsen patients' conditions and symptoms. Low oxalate food can lower the risk of developing kidney stones, especially for individuals that had their terminal ileum removed. The fiber should be added slowly, and soluble fiber is preferred, such as bananas, applesauce, and sweet potatoes. Raw fruit and vegetables and whole grains should be avoided at the beginning of recovery, and also as avoiding spicy foods, fried foods can help avoid stomach irritation. Since Elsie's duodenum was removed, she will need to take multivitamins, especially those that contain magnesium, iron, and calcium. Elsie should frequently be monitoring her glucose level, especially because of her diet changes. Her physician and dietitian will closely observe her weight, oral food intake, and lab values. Nutritional counsel will be advised to educate patient on the new dietary needs, as well as printed handouts will be given to her so that she can share them with her private chef. And here's my references list, and thank you for coming today.